Hi everyone, I'm Kristen Rosati. I'm a partner at Coppersmith, Brockelman in Phoenix and a past president of the American Health Law Association. I'm very pleased to join you today for the workshop. I'm sorry it can't be in person, but I look forward to the virtual discussion of these very interesting issues. In the short 10 minutes I have, I'd like to cover three issues that are all significant to the privacy and security of sharing information with oncology digital health applications. First, I'd like to talk about the patient right of access under HIPAA to get a copy of your own health information and to designate a third-party recipient to receive that information. Second, I'd like to cover brand new regulations called the Information Blocking and Interoperability Rules. And third, I'd like to give you a very brief overview of the privacy requirements for data sharing for treatment and research, which are significant to oncology treatment and research. And in particular, I'd really like to focus on the evolving standards of de-identification of genomic information. You'll see that I've included a number of reference slides at the end with more information on these laws so that you have that information if you need it, but we won't have time to cover today most of this information. First, I'd like to talk about two different patient rights under HIPAA that will be good levers to transfer information to digital health applications with patient permission. So first, patients have a right to get access to their own health information in the form and the format they request. This applies to information in what's called the designated record set, which are medical records, health plan, claims information, provider payment information, and any other information that's used to make decisions about patients. The second HIPAA right is the patient right to direct disclosures to third parties, including personal health records, digital health apps, and research databases. A court decision recently limited the rule to apply to just information in the electronic health records, so it doesn't apply to the entire designated record set, but it's still a very useful rule to get information to digital health applications on behalf of patients. So essentially, a patient will be able to send a request to a hospital or a physician group for them to share the patient's entire medical record with a personal health record or a digital health app of some type. And given the multiple healthcare providers cancer patients have, this is an incredibly important tool for patients to gather their records in one place so that the patient can share data with other treating providers in a more seamless fashion than happens right now. And there are two new kids on the regulatory block. The ONC, or Office of the National Coordinator for Health Information Technology, Interoperability and Information Blocking Rule, and the Centers for Medicare and Medicaid Services Interoperability and Patient Access Rule. The intent of these new rules is to remove barriers to data sharing and to put patients at the center of that data sharing. Unfortunately, the rules are incredibly complicated and dense, and it's really going to take a real uphill trudge for a lot of organizations to comply with these new rules. First, on to the ONC Interoperability and Information Blocking Rule. So this new rule is a huge paradigm shift in data sharing in the healthcare industry. Under the traditional HIPAA framework for data sharing, covered entities and business associates are prohibited from sharing health information unless there's a specific rule that permits them to do so. And the only required disclosure is to patients who ask for their own health information and to the Office for Civil Rights in an investigation or enforcement action. The information blocking rule shifts this presumption. If the rule applies to an organization, that organization will now be required to disclose health information unless a law prohibits the data sharing or unless they fall into one of 8 different exceptions in the rule. So the rule has fairly broad application. It applies to providers, health information exchanges and health information networks, and health IT developers of certified health IT. So if a digital health app, for example, is certified health IT, this information blocking rule will apply to that digital health app as well. There are unfortunately very large penalties associated with violations of the rule, up to $1 million per violation for health information exchanges, health information networks, and health IT developers. Providers are going to be referred to an appropriate agency for appropriate disincentives, which have not been defined yet. So the penalties are substantial. The compliance deadline is November 2nd, 2020. Although we are still waiting on the final Office of Inspector General civil monetary penalties rule so that we can understand more what these penalties will look like. The ONC rule also contains new technical certification criteria for API-enabled services, which will certainly be an important thing for digital health app developers to understand. So the same day the ONC rule was released, CMS released its Interoperability and Patient Access rule. Now this rule in large part just applies to government health plans. And these rules will require plans to establish APIs with any third-party app to share plan data, plan claims data, and any clinical data that a health plan can hold, subject to some exceptions. The key here is that plans are required to vet the privacy and security of these third-party apps and to educate their plan members about privacy and security of these apps. There are lots of questions right now about how this will be implemented and big concerns about individuals not being careful enough about their own privacy and security in enrolling in these third-party apps. And that's a concern because in the US, we currently do not have a federal law that protects all consumer data. And that brings us to the complicated web of laws that govern data sharing. Most of these laws are sector specific, at least in the United States. So it creates a real patchwork of laws that are difficult to follow and leave some data completely unprotected. So the most significant of the sector laws is the HIPAA rules. The HIPAA privacy rule applies to covered entities or business associates. Information may be disclosed for treatment of a patient and for research if it meets one of the HIPAA research rules. And by the way, I've covered those HIPAA research rules in the reference slides, and I've already discussed it applies to disclosures to patients and third parties where the patient directs disclosure to that third party. The HIPAA security rule governs the security of that information. And then what I'd like to focus on is standards for de-identification of protected health information and how those de-identification standards apply to genomic information, which is very significant for oncology research in particular. As you likely know, there are two ways to de-identify health information under HIPAA, the expert determination method and the safe harbor method. There's a thorough guidance document from the Office for Civil Rights on both of these methods that I cite here on this slide. And because so much cancer research involves genetic information, the question is whether genetic information can ever be de-identified under HIPAA. Intuitively, most people say no, because our genetic sequencing precisely identifies us. But remember that it only identifies us if someone has a register that matches your genetic sequencing information with information on your identity. So under HIPAA, at least as currently written, I think the answer is that genetic information can be de-identified. So genetic information is classified as health information under HIPAA, but health information isn't protected by HIPAA unless it's protected health information. And PHI is individually identifiable. The Office for Civil Rights, the agency that enforces HIPAA, has concluded that not all genetic information is individually identifiable, but unfortunately hasn't given us good guidance on when that is. So a common interpretation, and one that I take, is that genetic information is not protected health information under HIPAA unless it's accompanied by any of the HIPAA identifiers that directly identify an individual, like name or social security number, of course, or unless the entity releasing the information has actual knowledge that the recipient that will receive the genetic information has the ability to identify the individual. So, for example, the release of genetic sequencing data to 23andMe will likely be treated very differently by the Office for Civil Rights than the release to an academic medical center that hasn't treated the patient. But that conclusion may be changing as various standards evolve. Under the Revised Common Rule, for example, what is treated as identifiable information may be changing. So under the Revised Common Rule, the definition of what is identifiable private information, which is what is protected under that rule, didn't actually change, but the agencies that enforce the Common Rule are now required to assess whether there are certain technologies or techniques that should be presumed to generate identifiable private information, even if they're not accompanied by traditional identifiers. We expect that whole genome analysis will be first on the list for analysis. So it could be that if the Office for Human Research Protections or other agencies that enforce the Common Rule decide that genetic information or certain types of genetic information are identifiable information, those agencies could be out in front of the Office for Civil Rights for a period of time, which may create a disconnect between the regulations. Plus, state laws are increasingly important in the analysis of when you can use genetic information and when data sharing is permissible. Some laws apply to de-identified information, presumably including de-identified genetic information, and de-identification is usually not defined in state law. Some states actually provide that individuals own their own DNA and genetic information, and most states do not recognize a distinction between germline and somatic testing, which is pretty outdated by this point and badly overdue for a rethink. And state consumer privacy laws, like the California Consumer Privacy Act, are adopting different standards for de-identification of information, which pose huge challenges and practical problems for research initiatives. That's important because what happens in California doesn't stay in California. A lot of states mimic what California does. So there is potential disruption ahead in terms of using de-identified genetic information. I do want to note that there's a bill pending in California to harmonize the CCPA with the HIPAA de-identification standards, but that may or may not be successful. And there are even tougher standards for de-identification of information under international law, which we don't have time to address today. So how does a cancer researcher or an institution who is assembling cancer information or information about cancer patients, including de-identified information, cope with the evolving standards of de-identification? First, I recommend that it's a good idea to get a statistical expert determination of de-identification rather than relying on the HIPAA safe harbor method of de-identification. And the reason is you can get a statistical opinion to cover both HIPAA, state, and international standards for de-identification of information to cover the waterfront. There's also a recognition in the healthcare industry that it's important to be a good steward of your patient data, whether or not it's de-identified. So it is becoming increasingly common in the healthcare industry not to release de-identified data into the wild, but instead to impose contractual controls around a recipient's use of de-identified information. I've listed a number of bullet points here that are very common now to see in the healthcare industry in terms of releasing de-identified information to a recipient. This is good risk management in case the standards for de-identification of information change over time, and it also protects individuals against the increasingly likely possibility that their data can be re-identified by pairing it with publicly available data. And protecting information and protecting individuals is essential to engender trust and acceptance of the use of data for research, which of course is our ultimate goal. So thank you very much, and I look forward to the discussion.